you. Take it away.
I think, hi folks, I think Justin, you're going to do the slides. And we'll. So hello, and just on behalf of the team, this is really we're going to hone in on the response and community assessment, but I'll just give a brief summary or overview of the CTC, the Care Transformation Collaborative Rhode Island, a little bit of what our strategy is and how this fits in, the work around telemedicine fits into that. Sue Detling's going to actually present the meat of the information today to really go over that needs assessment, talk about the process and the results. And then Suzanne Campbell is going to finish up with just talking about what else is planned and the learning collaborative that is going on. With that, we'll start with the wild diagram that we use to try to describe our work in the next slide. But I'll give you a little bit of a background before we go there. So I'm seeing some chat stuff from Justin around accessing the deck. But so just an overview of CTC, the next slide. So we are a statewide multi-payer, multi-stakeholder, public-private partnership. So we really are convened through the affordability standards, which were passed by the legislature in 2006, I think it started, and began as part of, convened by the Office of the Health Insurance Commissioner and EOHHS, but really designed to be that partnership. We formally incorporated as a 501(c)(3) in 2015. But really the focus, as this says, is to really lead the transformation of primary care in Rhode Island and recognizing it's in the context of an integrated healthcare system across the board. And we've expanded a bit, as you'll see in the next slide, but focusing on the quadruple aim, which is the triple aim described here, plus what we're calling, is clinician and clinical team well-being, or right now, I think we're thinking about it as workforce well-being and development. And a lot of our work has expanded to do that. But we really are, it's all the major payers are on our board. They have a representation, and as do the major systems of care and primary care practices. So Lifespan, Stephen Lambert's on our board, Brown Medicine's represented, Coastal, and Integra, Prospect Charter Care, and some of the FQHCs, and they're very engaged. So essentially 75+% of PCPs in Rhode Island are practicing and have gone through the program, the PCMH program. And the couple of things to just think about too is we really expanded our work just because when you're dealing with primary care, patient-centered medical home is a necessary but not sufficient piece. And, as you're part of trying to build the primary care system that is going to lead to affordability as well as high quality. Obviously, the rest of the healthcare system engagement is very important. But we began early on to do work around integrated behavioral health as a key component of primary care, as well as using community health teams, community health workers and behavioral health clinicians and forming as extensions of primary care to work with high-risk patients with important social and mental health needs that were really not as engaged in primary care or needed a lot of other help. So with that, we'll go to the complicated slide that just tries to show how we're thinking about that. So So in here, this idea that the guiding principles are really trying to still get to patient and family driven, high quality care. And we recognize how important health equity is in that. And you really don't get there without engaging the community and connecting the clinic to the community. So we're trying to re-envision a little bit about recognizing that, essentially primary care that is engaged and connected to the geographies where their patients reside is a really important part. But just going through this, the affordability standards are something we kind of rely on to help drive this. And we work very closely with the Office of the Health Insurance Commissioner and Medicaid. And then we really recognize this use of expanded team-based care. We've done a lot of work with including and expanding working with pharmacists to be engaged, as well as the IBH clinician, as well as conceptually thinking about the community health teams, but also the core medical assistant and nurse and nurse care manager and work like that. The behavioral health work I talked about, really a lot of support. And then the community health teams, which we're seeing, both extensions of primary care, but then working very closely with the Rhode Island Department of Health and their work around the health equity zones and organizing community-based organizations to support community-driven processes. So that's an interface that is an ongoing, evolving work that we think is really important. And then, we recognize that a lot of the work has been done to focus on high-risk adults and all of that work because that's where the money is and the immediate return on investment. But we know that the quality of life and the health of patients and families is so dependent on the health of children. And so this idea of focusing on improving the links between some of the family home visiting programs, Department of Health, and we started our integrated behavioral health work in adults, have expanded that to pediatrics. We started the PCMH work in adults, but now have expanded it to PCMH kids. And a good portion of the pediatric practices have gone through this program, including the Lifespan, RIPIC, Coastal, FQHCs, and that. And then we know that primary care specialist collaboration is kind of a key to success into the future. It's an area that we've targeted for often, but we still are grappling, and we do have planned to what we hope will be an e-consult collaborative to work with a number of the systems of care, including Lifespan, Integra, Prospect Charter Care, likely to start with, to help them develop e-consult internally and hopefully then expand outside. And then this idea of increasing high value care, which includes a focus on low value care. And then just underneath, we've got kind of what we're recognizing as kind of foundations where technology, telehealth, areas like remote monitoring, it kind of crosses everything that we're doing, including data and that. And then the fundamental way we work, besides trying to inform policy, is really trying to develop implementation and learning best practices and doing collaboratives with very specific deliverables and offering practice facilitation for that work. And we are funded by the health plans predominantly for our core business and core work, but we've really used and leveraged a number of grants to help bring this improvement to Rhode Island. So with that, it's enough, and certainly if people have questions, you can put them in the chat, we can deal with them later, but I'm going to turn it over to the real star here, Sue Detling, who's going to talk us through the specific focus around telehealth that we engaged in.
Okay, so next slide. Thank you, Pano. Hop on to slide 5. Okay, so thank you for inviting us to share this telehealth initiative with you and your group. We're really excited about everything that we've been able to accomplish thus far and what we have on the horizon. So this particular initiative was initially funded by United Healthcare to do the practice and patient needs assessment, and also the learning collaborative. And then we secured funding also from the State of Rhode Island CARES Act. So we were able to offer this telehealth initiative to more practices. It is a 3-phase project. And the first phase, which I'll get into the data, was the assessment phase. We started towards the end of the summer, and that ran through October. And we're in the middle of our webinar series, and we're just launching our learning collaborative. And this project was managed by CTC Rhode Island with input from the core planning committee, with also some representatives from Brown. Really grateful to them. We have subcommittees. Our clinical strategy committee also helped plan this initiative. And if you've not heard of them or used them, the Northeast Telehealth Resource Center is a federally funded nonprofit organization that provides free technical assistance and resources around telehealth and remote patient monitoring and so forth. And there's actually these resource centers across the country, and they all collaborate together. So it's a tremendous resource. Next slide. The goals of the telehealth initiative is really to engage primary care, the primary care team, with best practice sharing opportunities, supporting effective, safe, efficient telehealth services, looking at the practice, staff, patient experiences, clinical outcomes, and access to care and utilization. And we're really hoping that this data is going to help inform Rhode Island healthcare policy on primary care practice patient telehealth needs. Next slide. We conducted this telehealth practice assessment and patient surveys. We had 47 practice sites engaged, and several of them actually were from Lifespan and Brown, Anchor Medical, the Adolescent Health Center, Brown Medicine, just to name a few. Practices who participated received $2,000. We had 35 adult sites, 12 pediatric sites, and over 900 patient responses. Each practice site was required to take a team approach, and really, so it wasn't just one person at the practice responding to the practice assessment. We really asked them to include all of the roles within the practice, the provider, the office manager, the nurse, the MA, the front staff. And they also were, the patient surveys, each practice site was supposed to survey 10 patients who had had a telehealth visit and 10 patients who had not had a telehealth visit. So this wasn't a research study. The selection of the patients was not random. I just want to put that out there. Anchor Medical really went above and beyond, and they took the surveys and sent them out via their patient portal. So more than half of these patient responses came from the 4 Anchor Medical sites. So we were really grateful for that effort. And from the practice assessment and patient surveys, we hope to address webinar topics, around what the practice and patient needs were, what their interests were. We allowed them to request particular topics, and then naturally we wanted to address the barriers. And throughout this, we have some quotes from patients. And when you get the slide deck, if you'd like to see the tool, at the bottom here, there's a link to the practice assessment and both patient surveys. Next slide. So in terms of the initiative, as I had mentioned, you can see here there were quite a few from Lifespan, Care New England. We had private practices, South Coast Health, several federally qualified health center sites, Brown Physicians, and Care New England Integra. Next slide. And this is the demographics of where these practices were located. And you can see the bulk are residing in the Providence area, Cranston, Lincoln. Next slide. So from all this data, we broke out, you're going to see several slides here with themes. There is a lot of data, and when you get the slide deck, you'll notice at the end we've included the data if you really want to dig down into it. But this is pretty much high level. As we know, telehealth really became essential once the COVID pandemic hit. And so the majority of the practices were using telehealth for primary care and behavioral health visits. You can see that 57% of practices were using it for the majority of their primary care, and an even higher use for behavioral health work. Interesting, 82% reported telehealth improved their work experience. And they preferred phone to video. Again, that's the initial rollout, roll it out quick. That's the easiest thing. Didn't have too many responses around remote patient monitoring. Next slide. So again, the top benefits, as we know, increased patient access, reduction in no-shows, staff appreciate being able to work from home, and ability to bill for their call services. And then this just shows top visits. So we have another slide on that. And things to improve in telehealth, and this is what we're focusing on with some of our webinars: patient education, better workflows. We know that the internet in the community can be a challenge, particularly in some areas of the state, and then staff training. Next slide. So the provider assessment, practice assessment, asked about barriers for themselves, and it also asked them to respond about what barriers were they seeing among their patients. So the top one was reimbursement, and we've already done a webinar on that. If you go to our website, you can see it. And then the barriers for patients: lack of technical understanding. Patients didn't know how to use a video or phone for a medical visit, which I'm sure doesn't surprise any of us. Next slide. So both practices and patients ranked the top types of phone or video visits that were offered to them and that they used. And these included medication management, sick visits, which we saw were the highest in those aged 19 to 54, whereas the routine follow-up for chronic condition management and ongoing care we saw in the 55 plus population. COVID concerns, a nurse care manager check-in, and then behavioral health visit. Again, no surprise there. So now we're going to get into the patient survey data, and this is just the demographics of those patients who had a telehealth visit and those who had not had a telehealth visit. We did really ask the practices to try and select patients with diversity, but you can see here, and we offered the survey in Spanish, but despite that, the majority were English speaking as their primary language. Next slide. And the insurance demographics, this shows a little bit more diversity in terms of the fact that we did have representation of Medicaid, commercial, Medicare, and some representation of no health insurance or other. Next slide. In terms of the patient surveys, we identified top barriers. Again, this theme you're going to see over and over again. Patients not comfortable or didn't know how to use a video or phone for a medical visit. They may not have had a computer or tablet for a video visit, or they might lack reliable internet or phone service. However, those who did do telehealth, the majority reported that the phone or video visit was indeed able to address what was bothering them, and they agreed or strongly agreed that they were satisfied with the telehealth visit. Furthermore, this was very interesting, and you'll see this slide further on, that telehealth really does help promote appropriateness of care. So patients reported that if they had not been offered a phone or video visit, that they may have gone to the emergency room or just simply not been seen by any clinician. Next slide. And so furthermore, patients who did have a telehealth visit, the majority of them were willing to have one again in the future. And they felt as though it was safer than in-person visits during COVID. They didn't have to leave home and it takes less time. And the phone visits were preferred for those age 55 plus, while the video visits were preferred for those age 0 to 54. Overall, people still prefer in-person visits. In terms of patients who said they would not have a future phone or video visit, they're uncomfortable, they may not have a computer or tablet, they're concerned about privacy, the phone or video visit might be too short, or the phone service is unreliable. Next slide. So for those patients who have not had a telehealth visit, and I would like to point out that when you look at the data, it's a lot of the reason they didn't have one, they just weren't offered one or didn't need one, but they would consider having a phone or video visit in the future. Again, some of these same themes: safer, they don't have to leave home, takes less time. Some of the same reasons why they might not do a video visit: just not comfortable, it might be too short, privacy concerns, and lack of reliable service. Next slide. Okay, you're like, wow, this is really a busy slide. It was a little challenging. We had open-ended questions, and so we really just tried to categorize them. I'm just going to talk about the top things that we saw. So again, from those patients who had a telehealth visit and those had not, basically 32% wished that they had been offered telehealth visits related to one of their health conditions, like behavioral health or a chronic condition, maybe related to their high blood pressure. And they also thought the visit could be improved by a more organized workflow. And I think just me personally and my family who've had telehealth visits, I mean, I would tend to agree with that. It's been a bit of a learning curve for practices. Similar for those who had not had a telehealth visit, they had the same sort of suggestions. Next slide. This next slide is going to look very similar. So this is, we asked for suggestions from patients on what could be improved in the community that might help with the community with telehealth. And so not surprising, and we do see this, technology education and public access. So there was even some suggestions about having rooms in libraries, private rooms that patients could go to. And then the fact that certain communities just really have a tough time with internet access. So could that be made available? And just learning how to use the technology. And again, we're addressing this in a webinar series. We're going to be having a webinar series. Well, we just had one on technology. February 23rd, we're having one on workflows, and we actually have Anchor Medical and a small practice, Barrington Family Medicine, is going to present. And then in March, we're going to have a training for community health workers so that they are equipped to help their clients understand technology. Next slide. All right, I'm not going to read through all these quotes, and actually there's 3 more slides with all the quotes, but this really does tell the story that patients appreciate having telehealth, and they may not have seen care. So suggestions such as help older people out, having the technology at local and privacy to conduct appointments at local places, some other improvements, ability to do vitals so that you can do physicals over the phone, and then things around workflow, calling a day before to remind of the appointment and time frame. Appointments scheduled by the patient portal is another great way, easy way to do it. Next slide. Here's the slide that I had referenced about appropriateness of care. So if the 55 plus, I'll look at that first. That red is, they indicate the majority or that, not the majority still said they would have, if they didn't have a telehealth visit, they would have gone to see the clinician in person, or just not have been seen by any clinician. And then for the 19 to 54-year-olds, a fair amount of people responded that they would have gone to the emergency room at the local hospital. They would have gone to see you, Dr. Rainey. But we know that that's not the most appropriate way to access your care. So next slide. I've been kind of sprinkling in our top webinar series. So coding, billing, reimbursements. You can look at that. You can watch it on demand if you like on our website. Selecting remote patient monitoring equipment. We actually are looking to do that more in the spring. Integration into EHR, technology, training for patients, and workflow. Those topics I think are really we're gonna have some nice coverage on those on our workflow webinar. And then meeting the needs of pediatric, geriatric, and special needs patients will also be addressed within the community health worker webinar. And we're looking to focus on pediatric needs and adult needs, maybe behavioral health needs in like May and June. So those are in the process right now. Next slide. I think actually that's it for the practice needs assessment and the patient surveys. I'll turn it over to Suzanne, who has just been wonderful in putting this whole collaborative together.
Thank you, Sue. And, also thank you to Pano for really helping to explain, what we try to do in the Care Transformation Collaborative. And so what we did then is we said, all right, let's have a call to action. Let's try to understand how we could do a better job with telehealth. And specifically, we were looking at how could we use technology to assist patients who had chronic conditions. And so we issued what we call a call for applications in November, and then we made our selection in December. And so the goals for our 12-month learning collaborative are basically to help practices improve on their quality measures, to help improve the patient experience, and then also to learn from each other. One of our founding principles that have been so terrific within Care Transformation Collaborative and PCMH Kids is that we form a learning collaborative, and some of the best learning is from like doing. So the idea is, how can we take it one step further? So practices implemented telehealth, and that we're trying to frame as one tool in the toolbox. How can they then go one step further and identify technology that might be able to be used in primary care to assist patients in the management of chronic condition? So next slide. So who responded? I think one of the things that we really tried to do is make things available on the adult family medicine side, as well as the pediatric side. And so we're really happy that we had a really good split. We had 21 practice sites apply, and 10 of them are pediatric practices. And you can see here what are the topics. As part of the call for applications, we asked practices, what do you anticipate is going to be your population of focus? Practices don't have to stay with that, but we asked them to identify what they thought was going to be their population of focus. And not surprisingly, on the adult side, you'd see diabetes, hypertension, heart failure, COPD, and asthma. And on the pediatric side, you're looking at mental health, social determinants of health, asthma, diabetes, and also obesity. So a wide variety of areas that people identified. Next slide. So how do we design our 12-month learning collaborative? We basically broke it up into two different phases. The first phase is, months 1 through 4, which we call our planning phase. And then the second phase really goes from months 5 to 12, where the practices have in the planning phase developed what their approach is going to be, who their population of focus is, what they see as their practice needs, what they see as the potential cost of the program, and then they design a performance improvement plan. So that's what they need to do in the first 4 months. And they have a practice facilitator who's been assigned to each practice site. In some cases, we have, based on the practice and what they're identifying, we have people such as like Sue Dentley, and then we also have a pediatric psychologist, we have a pharmacist, and then, and then we also have somebody who's working with health-centric advisors because they've really developed an excellent platform as well. And so in the second part of the Learning Collaborative, they've identified their performance improvement plan. And in that performance improvement plan, what we ask the practices to do is to identify what the workflow is going to be, what's the training that they're going to do for patients, what the training they're going to do for the staff, and then how are they going to measure success. They are then asked to implement that and do that test for change. The second piece that they're going to be asked to do is really risk stratify the population. And they're going to be asked to look at who are the patients that might need more assistance, whether that be in access to care, whether that's involved with being able to use technology, access to technology. And they're asked to really identify a plan to meet the needs of people that could benefit from technology but need more assistance. Part of this might also involve developing a community partnership. So that community partnership could be maybe working with community health workers that are part of community health teams. That might meet on the pediatric side. What about the family home visiting program, the CEDAR program, working in any of those kinds of things. So we think that at the end of the 12 months, they'd be asked to then also survey patients, find out from the patients, how are things working, and then really work to improve the plan. So at the end of the 12 months, I think we'll be in a really good position to be able to say what's working, what's not working, and see how we've been able to really look at another tool in the toolbox. So we have, the telemedicine is kind of like what people did that's been really successful, particularly during COVID-19. But now the second thing that we're going to be looking at is what are the other tools in the toolbox that could be considered to really help some of those patients. I just would refer back to what Sue referred to, which is that patients are going to see primary care for vital signs, or they might be going to see primary care for attention deficit disorder monitoring. Can some of that get done, in the comfort of the person's home or at school? And, how can we really, move the bar on this? So that's basically the design of our Learning Collaborative. Those are the practices that we're so grateful that are participating. And the reason I say that is because this is not the easiest time for practices to be saying, let's do one more thing. And again, we were so appreciative to United to really provide funding for the practices. They'll be getting between $20,000 and $22,000 each for this work. And that's really to help support their efforts. So I'm going to stop there, and we'll see what other questions you might have. I'd also refer, Sue also put together some really nice slides that give you more information on data. So if you really want to drill down into the, what practices said, what patients said, there's some more slides in the slide deck, but we wanted to really give enough time for questions and comments and see what you think. So I'll stop there.
And this is Pano. I would just add, I'm not sure how many folks are paying attention. I wouldn't expect it unless you're in the midst of it, to the health insurance commissioner. And there were several meetings, in fact, a series of 5 or so with the health plans. There were public meetings to look at reimbursement policies. And one of the big struggles has been around valuing, do you value a telemedicine visit at the same level as a in-person visit? And certainly in the emergency declarations and perhaps some COVID related, the answer was yes. But then the idea was, what's the recommendation going forward? And there was a real back and forth about a video visit versus a phone only visit. And the idea was that maybe for behavioral health, yes, but for a physical health, that maybe you'd value it less if it's phone only. But then if you circle back and look at patients and their preferences, phone visit is a high on the list if they're going to do telemedicine, and especially if there are technology barriers and other things like that. So it's an interesting dilemma that hasn't been solved. But that was one of the issues, for example, that really was a sticking point in that series of meetings.
And Pano, that's a really good point. I just want to mention that that series of meetings did not deal with reimbursement for remote monitoring. So part of the problem in terms of the uptake with remote monitoring is there isn't a really good population-based approach across all ages to supporting remote monitoring. So again, we're hoping that, if we can get information that says this is really helpful to patients, this makes a difference, it would then also help to inform public policy in Rhode Island.
And I have to say that the remote monitoring part, I'd love to hear your thoughts more about that. I think both from the perspective of the Center for Digital Health, and I know one of our CDH leaders is an engineer who's been doing a lot of work around remote monitoring. So both from the scientific development perspective, but also from the perspective of being a clinician myself who provides telehealth, right? And doing those COVID visits are really tough if a patient doesn't have a pulse ox at home.
Mm-hmm.
So it would love to hear your thoughts both around kind of, as you've acknowledged, the reimbursement is a huge issue, but if let's pretend that we had reimbursement, kind of where you would like to see this go or what things you would like to push for.
Well, patients, I guess I'd start with what patients said. And patients said, there was 28% of the patients who said they would like to be able to have, be able to do remote monitoring with vital signs. Now, what will we find when we actually pilot it? We'll find out. But I think that it's a terrific tool around patient engagement, so that if you can help somebody learn how to use it in their home and then be able to see how they're doing and then be able to how to get that information to the provider, I think it's going to be really, I think patients are going to say this is really helpful. And I also think this might, in terms of patients who are older, that family members are going to really appreciate it too, because when you think of moving people to the doctor's office, it's like the family that's got to get everybody there too. So there's a lot to be gained from this. However, I would also go back to one of Sue Dentley's slides, which said that patients really value inpatient care. So again, this is a tool in the toolbox, and that people really value the relationship they have with their provider and with their team. So it doesn't replace things. I think it really augments it. That would be what I'd say based on looking at our data. I don't know.
Yeah, and it's not an either or at all, as you're saying. There is plenty of data around heart failure, patient monitoring, and reduction in hospitalization and ED utilization. There are sites who have already moved forward, and we just hear anecdotally from one of our pharmacists, and we're really interested in, kind of the clinical team engagement in using remote patient monitoring and telemedicine. But pharmacists saying how fantastic, just a series of a dozen patients or so with very hard to control hypertension on multiple medications, with engaging them in a pharmacy-led remote patient monitoring process and having their blood pressures get under control in 4 to 6 weeks. just with that kind of feedback. And, part of it you imagine is taking their medicines, now getting a little bit more. So we don't know all the reasons, but that kind of success. And, we're really, we also have a major initiative in concert with Medicaid and the Health Insurance Commissioner and the health plans, which is to move Rhode Island more towards primary care capitation, comprehensive primary care capitation, supporting the CPC Plus model, and even going further than that. That whole question, then, remote patient monitoring becomes a different, coverage. So it wouldn't be necessarily included, but maybe parts of it might be. But this whole idea that you can begin to use your clinical team and engage patients in a what's effective clinically and more on what they prefer, they being the patients, where you could really expand text, telephone call. You wouldn't have to worry about, is it a phone call, a face-to-face visit, or a video visit? You would do what works clinically and for the patient in the best way. So that's, we think, is an important kind of secular trend that is involved with all this.
Hi, everyone. I just want to point out something I was really struck by in the presentation. On slide 10, there were some just percentages reported out from the data, but what was most interesting I found was that 91% of the practices that you all work with made the transition to telehealth in March of 2020 because of COVID and the CARES funding and the work that you all are doing. And it brings up an interesting point that community-based medicine isn't as technologically advanced as major health systems that are now branching out into accountable care models and primary care-based models. And to see the way that you've worked with these practices and to hear how you've kind of propelled them forward, and most of the practices that you've worked with being in an urban setting where access to care is physically there, but from a socioeconomic standpoint, it's not accessed in the same way by populations in urban settings. But 91% of the practices that you're working with were not using telehealth beforehand, and it just speaks to the effect of your work, the rapid transition they've had to make, and the support that has been provided by you all. It's just fantastic to hear. And I have a background in health IT, and something that always struck me is the capital-rich organizations like Lifespan Care New England, South Coast, Prospect Charter Care have resources to build out these systems, workflows, and infrastructure, but community-based or independent practices don't, which could, kind of further divide the quality of care between the two. But here is where CTC fits in so nicely in, being able to support community-based medicine to, be just as effective and just as technologically savvy as a Lifespan, a Care New England, a Prospect Charter Care.
So just to maybe to just put a little bit of extra context, I think the majority, most of the practices are affiliated with systems of care. So they were all part of those pieces. But I think Rhode Island mirrored what happened, as we know, in the rest of the country, is that everyone went to telemedicine in March, and they did it in a very haphazard way out of necessity. Many of them literally overnight or within a few days. So what we do is we provided a venue for people to share best practices. That early on, Doxy ME was kind of the seen as the more flexible system for most of them. It was free or lower cost if you went to their higher premium than some of their EHR specific platforms and other things like that. And then it took folks a while to settle down. So we didn't do anything ourselves to propel it at that early stage, except we did bring folks together in frequent meetings to share best practices and learn about what they were doing and stuff like that. But even those resource rich, entities did not have any of this capacity, just because telemedicine was really, even though there were codes, there was reimbursement, it was just not at the top of anybody's list.
And I would say that in Rhode Island, you probably all know this already, but we have the Rhode Island Health Insurance Commissioner. And that is an incredibly positive force because, she was able to pull people together. She was able to say, this is what commercial insurance is going to do. This is what, Medicaid is going to do, and really move things through. And so not to underscore the importance of leadership and policy in making things happen and then work. So we need that continued. I mean, like that's still going to be needed and continued. And I think in Rhode Island, we're really well positioned because we've got strong leadership. My opinion. Anything that surprises you, like you would have thought you wouldn't have thought, or anything that, like, as you look at what people said or practices said,
Make sure that
you think we need?
Absolutely, thank you. And I want to make sure that some of those who I know have their videos off or maybe haven't had a chance to speak have a chance to ask questions too. Thank you, Suzanne. That's a great question to ask us.
Hi, thank you so much for taking time to present this to us. This is awesome to see. As a little background, I'm a PhD student and I specialize in healthcare tech and understanding how advancements in that can influence outcomes, influence costs. I just had a question if there was any level of, and I may have missed this, but if there was any level of income or self-identified race or ethnic data that was in this, because I was curious just because understanding the ways that some of these technologies can kind of cleave themselves based on those lines. I was curious if there was any differential findings there.
Sue, do you want to take that?
Sure. So again, nothing of statistical validity. We did have some help with a graduate student at URI to look at the data. I mean, we saw differences in age about, whether or not they were comfortable using telehealth. And we did ask the practices to try and, select diversity within their patient population. But there was nothing of any statistical validity. And for some practices, it was really challenging just to get them. Well, Anchor Medical didn't have a problem. They did everything by their portal, but we had another federally qualified health center. Incidentally, the CCAP, federally qualified health center, uses Brown medical students, and they use the Brown medical students to help conduct these surveys. And so they have 4 sites, and they needed to get 20 patients from each site. And they had to really reach out to over 100 patients just to get these bare minimum. So, part of that could have been, and I think we're all experiencing this working from home, if their telephone didn't say that the call was coming from CCAP and it was just I don't answer calls when I don't know who's calling. So, I mean, there were experiences like that made us think about how we might improve this type of surveying in the future. But we did ask questions about income and race and that sort of thing. Just nothing that showed up of any statistical validity.
Thank you.
I think one of the things too that we're going to be looking at in terms of the workflow is how do you, within your platform, how do you also integrate the interpreter? And that's a really important feature that practices have struggled with, to tell you the truth, because some platforms are better than that, being able to do that than others. And I think the other thing just to keep in mind, we were just talking about this today, that people might have started with one platform or one tool and it worked for this situation. And similar to when, we all went to, transitioning to EHR, right? This was the state of art as we had it, when we were making decisions about, the EHR. It's going to be the same thing, I think, in telehealth. People are probably going to be evolving to, you know, better systems, better equipment, all those kinds of things, because if the state of the art will increase. And that's why it's so great that we have this Digi Health Center, because it'll really help us. Like, what are the needs? And then how can we work together to really develop tools?
Well, and I think part of that kind of from our perspective is that, yeah, to echo off of Nick's question, as you see these key things that need a little deeper dive, perhaps, you know, knowing that you're a practice-based collaborative, not a research-based collaborative, right? And so if there are things that can transition or kind of be shared with folks like, again, Nick, not to put you on the spot, but as a current PhD student who's been working with us, right? Is there something that someone like him could have taken on at some point that could be helpful and both move his career forward and move your work forward? I think that's kind of one of the things that we're always interested in. So,
Nicholas, if you see some of those conditions that people are have identified as their population of focus, and you think, I'd love to work on something, let us know.
Thank you so much. I definitely will.
Yeah, and I mean, there could be some opportunity when we get to the point of where we're really trying to hone in on the practices, identifying those extra vulnerable patients, you know, and just really setting it up in the right way to be able to measure success. So I think that's probably going to be a focus of one of our Learning Collaborative quarterly meetings.
And certainly it's a separate set of data, but you know, the whole population that gets served by the community health teams, the statewide network, the demographics, the real big difference is non-English speaking versus the Rhode Island population. And that's, you know, not to be no surprise, but that's a population. And so those tend to be, have the most difficulty, at least a subgroup of the more difficult in terms of using technology and accessing.
Megan, if I, hi, yes, thank you. I'm Rebecca Armitage. I work with Megan. I'm from Brown Emergency Medicine, and we're working on a telehealth platform too. So thank you. This is really, really good information, especially from the populations that are out there that may not come into the emergency room. And I just have, I guess it'd be more of a research question. I'm interested in, as part of your, maybe your phase 3, I didn't see it in there, is the difference in if you do a follow-up on survey on some of these and maybe the different types of answers you receive. And by that, I mean, maybe it's the over 55 population who at the beginning of COVID, maybe was not as familiar with technology, but now as everybody's used Zoom to speak to their kids and speak to the grandkids and the grandparents, are we seeing a level of that come up? And does that make it, I don't want to say easier for community medicine, but there's a bit more of an uptake of it. And if that's part of your phase to redo some of the survey.
You know, that's such a great question. Interestingly enough, we're talking to a community health worker who's going to be part of our webinar series. And he was saying that when he tries to help people learn technology, they'll say, I don't really know if I can do this. And he'll say, but like, think about it. You could, you know, you could do things with your grandchildren. You could do things like, it's such a great tool aside from everything else around social isolation. And so he was saying that once you can get people to step 1, it opens up a lot of doors in not just telehealth, but, you know, connecting. So I think that we don't have that built in, but it will be interesting to see if we might be able to find out. I don't think you can, if somebody says, I don't think I can do it, I think it's helpful to find out like, oh, what are you missing by not doing it? And then seeing how you can move people along to trying, you know, because he said it's been great to be able to see people learn and then expand their horizons.
So Rebecca, I think that's a really good point. We one of the partners that we've worked with is from the Rhode Island Geriatric Education Center. And so we've done several things with them. And I think that might be a way to proceed to answer your question. we'd be a little reluctant, but if we got more funding to ask patients or ask practices, oh, could you redo this survey now? Because we didn't have that built in, but that might have been a good thought had we thought of it earlier on.
Isn't that always the story?
Right. We should have come to you all first. Anyway.
We've all learned, I think, as we've gone, right? That's the joy of doing this stuff. So, well, I unfortunately, guys, have to run. I know it's the top of the hour. I'm happy to let you guys chat if you want to keep going, but I'm really honored and excited to have you present this. Hopefully it's helpful both to those who can attend and to those for whom we'll provide the recording, again, with your permission on our website going forwards. Look forward to having you keep being part of the conversation. And the last thing I'll say to the three of you is that if there are specific asks or kind of things that you'd love to have us kind of identify, we always have students and trainees and who are looking for projects. And so I'm happy to kind of share stuff if you'd like us to list something or kind of keep it in Justin's mental file of projects that we can direct folks towards. So feel free to kind of give follow up on specific things that we could help link to.
Thank you so much. I also have to go.
Thank you for this opportunity. Yeah.
Bye, guys.
Okay.
Thank you.